Good morning. Welcome to the Drugs, Vitamins, Valves, the Diversity of TB Clinical Trials session. My name is Paul Nunn. I used to work for WHO, but I'm a consultant now. My co-chair has not yet put in an appearance, but hopefully will do so shortly. What I propose we do is we quickly go through your presentations. Because these are short abstract sessions, I'm going to restrict people seriously to time. If you speak over 5 minutes, you will have me on your back, as it were. And we'd like to start, I think, with the number one. We'll just go through them in the order that's printed. So this is Dr. Saunders, is it? Can micronutrient supplementation prevent TB in vulnerable household contacts? A randomized controlled trial that's been going on for many years. Could I also remind you, while Dr. Saunders is heading for the microphone, to turn all your phones onto silent, please. And I will just say now, lest I forget later on, that if you wish to ask questions, please could you do so at a microphone. I'm sure you can make yourselves heard without using a microphone, but the session is recorded, and unless you're near the microphone, your voice will not be picked up for the recording. So that's the reason. So thank you very much.
Thanks. Please. Sorry, how do I get the slides to appear? I'm pressing the button, but nothing is happening.
I expect it will in a moment. Could we have the slides for the first presentation, please? First presentation slides. This is what's called a PowerPoint moment.
Here we go.
Very good.
Great. So thank you very much for inviting me here to talk to you today and report the results of a randomized controlled trial evaluating whether or not micronutrient supplementation can prevent TB disease in household contacts. I'd like to just thank, first of all, and acknowledge the research team in Peru. I'm joining this process very late, and without all of their hard work over the last 15 years collecting these data and doing follow-up, I wouldn't be able to present the results of this trial. It's well established that undernutrition is an important social determinant of tuberculosis incidence, with vulnerable populations who are at risk of TB deficient in a number of micro and macronutrient deficiencies that are implicated in the pathway from TB exposure through to TB infection and ultimately through to progression to tuberculosis disease. So the aim of this study was to evaluate in a clinical trial whether or not micronutrient supplementation with vitamin D, vitamin A and zinc can prevent tuberculosis disease in household contacts of people living with tuberculosis. We focused our research on contacts who are aged over 15 because in Peru at the time of the study, the National TB Programme prioritised preventive therapy for children, and also due to the uncertainties in diagnosing tuberculosis in children, especially in a resource-constrained setting like Peru. So the study was conducted in Bentanilla, which is, you can see in the two photographs at the top of the slide. Bentanilla is the name given to a collection of 16 peri-urban slum towns. A large proportion of the population are migrants that have come from the mountains and the jungle area of Peru looking for better work, for more economically productive work. And people typically live in quite rudimentary housing, and access to services is pretty poor. So we began by identifying index cases who we defined as the first member of a household who had received a diagnosis of laboratory-confirmed pulmonary TB. Once we had identified our index cases, we identified their household contacts over 15 years old and invited them to participate in the study. They completed a detailed questionnaire characterising risk factors for TB, and we offered them baseline tuberculin skin testing to test for TB infection and weighed them and measured them. We then randomised them using number tables to receive one of either 6 months of daily combined vitamin D, vitamin A and zinc, or 6 months of daily placebo. The tablets were inert in appearance. Participants were blinded to their allocation, as were the nurses who work in National TB Programme health posts, who are responsible for diagnosing and treating TB disease. And the tablets were also similar in appearance. So once we'd recruited participants, we followed them up every 2 weeks, visiting their homes and performing pill counts to measure adherence. And our primary outcome was the time to development of TB disease. We ascertained TB disease using National TB Programme records, their cards and their books. And we also performed 3 prevalence surveys, the most recent one finished in February 2016, where we visited all of the households that we'd recruited. We asked participants if they would like to provide a sputum sample, which we tested for TB with smear and culture, and we asked them about TB episodes that had been treated outside of the jurisdiction of the TB programme. Moving on to the results, so 40% of the participants were males, the median age was 30 years. Adherence to supplements was very good, so 83% of contacts took at least 3 months of supplements. The median number of days was 154 in the placebo group and 145 in the micronutrient group. So we followed participants up for a median time of 11 years, totaling nearly 19,000 person years. And during that time period, 177 of the nearly 2,000 contacts developed TB, equating to an incidence of 930 per 100,000. I just want to stop and focus on that number for a minute and highlight how high that is when we think about the incidence of TB in Benton as a whole, which during the study period was about 200 per 100,000. So these household contacts, these adult household contacts, had a much higher incidence than the general population. Moving on to the analysis, so in intention to treat analysis, the incidence of TB in the placebo group was 910 per 100,000 and in micronutrient group was 950. So we didn't observe any significant protective benefit of 6 months of micronutrient supplementation. If we look at this graph, you can see the time from exposure here and the cumulative risk of TB disease. And the light blue are the placebo group and the dark blue are the micronutrient group. We didn't observe any protective benefit at any of these time points with these supplements. Subsequently, we performed a number of sensitivity analyses, so we considered only incident TB, so cases that were diagnosed after 2 months after the index case had started his treatment or her treatment. And we considered a number of different subgroups, contacts who had good adherence, we defined as greater than 80% of pills taken. Contacts who were TST positive at baseline, so putatively they had latent TB infection at baseline. Contacts from the poorer half of TB-affected households, and contacts who had a BMI under 20. And in all of those subgroup analyses, we didn't observe any protective effect of micronutrients. So to conclude, in this randomized controlled trial, clinical trial, 6 months of micronutrient supplementation with vitamin D, vitamin A and zinc had no effect on the short or long-term risk of tuberculosis in these household contacts. We therefore wouldn't recommend them to be included in TB prevention interventions without further evaluation. And just thinking about a broader point in the results nicely show here, TB prevention interventions and national TB programs rarely prioritize adult contacts, despite them being an extremely large group who have got a clearly a high and prolonged risk of tuberculosis disease. I'm going to be talking on Friday about how we use the results of this trial to develop a TB risk score to identify which contacts are at highest risk, to evaluate how we can actually target TB preventive interventions to people who are most likely to benefit. So thank you very much for listening. It's a real pleasure to be able to speak, and I'm happy to take any questions.
Thank you. Any questions for Dr. Saunders?
Yes.
You need to go to a microphone, please.
Hello?
It's all right. Keep
Is it working?
I think
Okay.
so.
I just would like to know if you measure any other outcomes, if there were any other health benefits from taking microsupplements, or if you were just working on TB.
No, so we measured anthropometry, so BMI and arm circumference and skin thickness at baseline and after 6 months. Although in all of those measurements there were increases, there were no differences between the placebo and the micronutrient group. And we also asked contacts at our regular follow-up visits every 2 weeks about symptoms they experienced, things like diarrhea, headaches, just general well-being symptoms. And we didn't observe any difference in the proportion of days per month of symptoms reported in the two groups. So
Question on the left, please.
So I was just wondering, in terms of the prevalence surveys that you did in this group, I mean, obviously a big part of transmission is the time it takes us to diagnose people.
Yeah.
So if you were picking up people earlier in their TB process and maybe reducing the transmission in the communities, in the households, might that have had an impact on your power?
I don't think so, because I haven't been able to present the data here, but the vast majority of the cases, nearly 80% of the cases, occurred in the first year. And subsequently in our prevalence surveys, we detected very, very few cases. And the cases that we did detect were what the contacts had told us, that they were treated outside of the TB program. I think in our last prevalence survey, we got 1,500 sputum samples and only one of them was positive.
Last question.
So how did you control the intake of vitamin A, vitamin D, and zinc in the placebo group from other food sources?
We didn't.
Did you have any evidence for vitamin deficiency in that group?
Yes, so I haven't presented these data. We took samples for vitamin D and vitamin A and zinc, but blood zinc is kind of hard to analyse. But of the vitamin D data that we've analysed, 50% of contacts were deficient, and our supplements did significantly reduce deficiency.
Okay, thank you very much indeed.
Thanks.
It's a useful negative result study, I think. Right, next up is the effect of moxifloxacin on QTc interval in adults with pulmonary tuberculosis, a study with D. Nair as the first author. You ready to present?
Yeah.
5 minutes.
No, this is.
There you go.
Good morning. I'm from the National Institute for Research in Tuberculosis, India, which is one of the prime research institute for tuberculosis under the Indian Council of Medical Research. So the title of my study was Effect of Moxifloxacin on QTc Interval in Adults with Pulmonary Tuberculosis. So a little bit of background. We know that fluoroquinolones are widely used in acute bacterial infections. They have a propensity to prolong the QT interval, which is in a dose-dependent manner by inhibition of potassium channels. The QT interval on a surface electrocardiogram is measured as the time from onset of ventricular depolarization to the end of ventricular repolarization. That is from the beginning of QRS complex to the end of T wave. It actually quantifies the flow of ion currents across the cell membrane of ventricular myocytes and through specialized channels. And when these channels malfunction, they disrupt the normal cardiac rhythm and lead to cardiac arrhythmias. So QT interval prolongation predisposes to ventricular tachyarrhythmias and Torsades points. It assumes clinical significance in case of presence of risk factors like female gender, advanced age, familial long QT syndrome, liver and renal dysfunction, severe electrolyte imbalances. Hence, it's monitored and used as an endpoint in clinical trials. Though all patients who have a prolongation do not proceed on to develop Torsade points, it places them at a risk of sudden cardiac death. Hence, the regulatory agencies emphasize the importance of QTc assessment in development of new drugs. And since the patients are mostly asymptomatic, QT interval prolongation can be used as an indirect surrogate of predisposition to induction of Torsades points. So moxifloxacin is a 4th-generation fluoroquinolone which has promising antimycobacterial activity. It's being evaluated in randomized controlled trials for shortening the duration of TB treatment. Though there is data on short-term safety of short-term use of moxifloxacin, there's a little information on safety of moxifloxacin when given for longer duration, especially in Indian population. So we at National Institute for Research in Tuberculosis, we are conducting a trial to study the efficacy and safety of moxifloxacin containing regimen. It's a phase 3 randomized controlled trial where we are to study the efficacy and tolerability of 3 and 4 month regimens containing moxifloxacin, the treatment of patients with sputum positive pulmonary TB. And we would like to present here an analysis on the serial ECG data in the patients enrolled in this trial. So all newly diagnosed sputum positive pulmonary TB patients, HIV seronegative patients were enrolled. They were randomized to moxifloxacin regimens of 3 and 4 month duration or a 6 month standard regimen. And in moxifloxacin regimen, we gave 400 milligrams of daily moxifloxacin along with other first-line anti-TB drugs. Patients who had a prior history of cardiac disease and abnormal ECG or those with QTc of more than 450 milliseconds at baseline were not enrolled. So we recorded ECG at baseline or pre-treatment at first, second, third and fourth month of treatment. We did a 12-lead ECG evaluation. Timing and registration techniques were standardized. And we did unscheduled ECG evaluations for patients who had a QTC of more than 450 during treatment. And if it was persistently high, the patients were referred for cardiologist opinion. At each visit, we also assessed
You've
the
only
heart
got
rate,
1 minute left.
heart rate, pulse rate, PR interval, QRS, QT, and QTC intervals. The QT intervals were adjusted using Besset's correction. Mean QTC was calculated at each specified time, and we also did a stratified analysis at different time points with the different variables. So there were 602 patients involved, 476 in moxifloxacin regimen, and majority were males with a median age of 35 years. 193 patients had a sputum culture grading of 2+, and 466 patients had extensive lesion in chest radiograph. So these are the results which we've compared the mean QTC in control and moxifloxacin group, and we did not observe any statistically significant increase in mean QTC interval in either group. And we also did a stratified analysis, and we could not demonstrate any association with these variables. And we also evaluated the other parameters like heart rate, pulse, PR interval, QT interval, and there was no statistically significant difference in either group. So, but however, in 5 patients, we had to withhold moxifloxacin because there was an increase in QTC, but it was later on reintroduced without any incident cardiac effects. Only in 1 patient, on advice of cardiologist, we had to terminate moxifloxacin, and there were no instances of arrhythmias either. To summarize, in adult patients with pulmonary TB without any cardiac risk factors, moxifloxacin given daily for 4 months did not cause an increase in QTC interval, and we could not demonstrate any association between the mean QTC and age, gender, body mass index, baseline culture grading, and lung zone involvement. So we conclude that moxifloxacin at a dose of 400 mg given once daily is well tolerated without any adverse cardiac events. And I would like to thank all the patients who participated in this trial, staff of NIRT, Indian Council of Medical Research, and the union for giving us this opportunity to present this small study of ours in this big forum. Thank you.
Thank you very much. Any questions? I mean, one of the key issues is not so much moxifloxacin itself, but will there be effects on the QT interval if you use moxifloxacin with other drugs? And the big concern at the moment, of course, are things like bedaquiline and the other new drug, delaminid. Do you want to comment on that? What other drugs did you have in this study?
In this trial, we had moxifloxacin and other standard drugs like INH, rifampicin, ethambutol, and pyrazinamide. We have added moxifloxacin to the standard category.
So you were not really looking at the potential culprits for QTC problems, yeah?
Just moxi.
Hi, I'm Animesh from India. The ECG measurements that you did after the patient started treatment, were they pre-dose or post-dose?
It was after dosing.
Approximately what time?
Approximately half an hour to 1 hour.
Okay.
I mean, presumably after some time, patients were in steady state anyway. Patients would be in steady state with moxifloxacin concentrations after a while. Okay, thank you very much. Third up is bedaquiline for extensively drug-resistant or pre-XDR Mycobacterium tuberculosis, the interim results of an early access study.
Good
Floor is
morning.
yours.
Good morning, dear Chairman, dear colleague. I would like to welcome you on behalf of the expert group which participated in the study of safety and efficacy of bedaquiline in treatment of pre-XDR and XDR TB patients. The main purpose of our study is the substantiation of a need to include bedaquiline in the chemotherapy regimens for treatment of patients with pre-XDR and XDR TB. This group of patients is in need of additional chemotherapy drugs for adequate composition of their treatment regimens. We also believed it was very important to evaluate tolerability and cessation of bacterial excretion confirmed by culture in patients under treatment with bedaquiline-containing regimens. 57 patients who received bedaquiline in the combination with the other drugs of the basic chemotherapy regimen for 24 weeks were included in this study. This group of patients then continued treatment with the basic chemotherapy regimen for 96 weeks. The total duration of chemotherapy was 120 weeks. By the time of the preliminary results, preliminary analysis, 31 patients completed treatment, 19 patients were still on treatment, and 7 patients discontinued treatment. 58% of all patients under study were women who prevailed in the group. All patients were of Caucasoid race, the residents of Russia and Lithuania, with the median age of 28 and the age range from 18 to 61 years of age. 53% of patients under study had XDR-TB, 25% of patients had pre-XDR-TB with additional resistance to fluoroquinolones, and another 33% of patients had pre-XDR with additional resistance to one injectable drugs. All patients were HIV negative, and almost all of them were previously treated with the second-line TB drugs. Chemotherapy regimens of all patients included fluoroquinolones of the latest generation, levofloxacin or moxifloxacin. The most frequent component of the regimen were pyrazinamide, cycloserine or tirizidone, capreomycin, and PAS. And 65% of patients received linezolid. The safety analysis showed that 7 patients discontinued treatment, of them 5 due to serious adverse events, and plus 3 patients died. 2 patients discontinued treatment with bedaquiline due to the development of toxic nephropathy and depression. According to the expert evaluation, 3 cases of death were not related to treatment with bedaquiline or drugs from the basic regimen. All death cases were reported more than 1 year after initiation of treatment with bedaquiline. 2 of them occurred during treatment with the basic regimen only and were related to pulmonary hemorrhage as a complication of TB. 1 patient died during his follow-up after the course of chemotherapy was completed. The reported cause of his death was acute myocardial infarction. In all cases, at the 24th week of treatment with bedaquiline, the values of corrected QT interval did not exceed 450 milliseconds. Some adverse events, regardless of their severity, occurred in 50 patients under study. Most frequently, we observed an increase in the levels of AST in 27 patients and of ALT in 15 patients. Eosinophilia developed in 13 patients, and yet, according to the experts, 1 case of eosinophilia was not associated with the use of bedaquiline. 6 patients had reported adverse events were possibly related to bedaquiline. They included increased levels of AST, ALT, prolonged QT interval based on ECGs, increased levels of creatinine, blood urea, hematuria, leukocyturia, proteinuria, dermatitis, and hypertension. Any serious adverse events were reported in 8 patients. They included asthma, pulmonary hemorrhage, appendicitis, psychiatric disorders, 1 cervical cancer, and surgical intervention. Severity grade 3 and 4 adverse events were reported in 15 patients. Of them, the most frequent ones included increase on levels of AST in 4 patients and ALT in 5 patients. And treatment success was assessed on the basis of bacterial conversion by culture at the 24th week of treatment. Among all patients under study, the treatment success rate was 69%. In XDR-TB patients, the rate was a bit lower, 65%, and maximum level of treatment success was achieved in a group of patients with pre-XDR-TB, 72%. And in conclusion, it should be noted that bedaquiline, in the combination of the other drugs of the basic regimen, is well tolerated by patients with XDR and pre-XDR. When evaluating the drug safety, the researchers did not identify any new adverse events. Currently, there are 3 reported death cases, which is 5% of all patients included in this study. And with use of bedaquiline, treatment success rate of the pre-XDR and XDR-TB reach higher levels. More details result of the study will be presented to you later. So far, the study goes on. And thank you for your attention. Sorry.
Any questions? Could you please go to the microphone because the session is recorded. You will not be heard if you're not near a microphone. And I'm sure you want to be heard for posterity.
Has any patient developed resistance to bedaquiline?
We don't know. We don't assess this.
So these sound like reassuring results given the phase 2b concerns about bedaquiline and the deaths in the bedaquiline-treated group in that original study. What about the pulmonary hemorrhages, though? What do you put those down to?
Pulmonary hemorrhage is a complication of TB. It was high, severe TB in these patients.
And do you think it had anything to do with platelet damage caused by any of the drugs that they were taking?
We believe that is not related to any drugs.
You think it's just serious cavitating
yes, serious disease. Yeah.
Okay. Any other questions? Oh, thank you very much, Dr.
Thank you.
Vasilieva. Right, next one, we're back to Peru again. Resistance to pyrazinamide and ethambutol among MDR-TB patients in a clinical trial in Lima. And this is going to be presented by Dr. Carolina Moran on behalf of Dr. Martel.
Good morning, everyone. My name is Carolina Moran from Peru, and today we are going to talk about resistance to pyrazinamide and ethambutol among MDR-TB participants in a clinical trial Lima, Peru. They are the authors and their respective affiliations. Okay. A little background about this clinical trial in the context of MDR-TB participants. We can say that there's a efficacy of the second-line treatment using with pyrazinamide and ethambutol could be compromise the amplification of resistance and by transmission of strain MDR-TB resistant to these drugs. Also, there is interest to shorter standardized regimens for MDR-TB cases. In these minutes, we are going to just describe the frequency of resistance to those drugs, pyrazinamide and ethambutol, in the context of clinical trial called OptiQ, that it was a phase 2 dose-ranging trial of levofloxacin for treatment of MDR-TB. Okay, what do we do in this clinical trial? We screen 81 participants with high risk factors for MDR-TB from January 2015 to August 2016. They complete all inclusion criteria, and from these 81 participants, just 34 complete the all inclusion criteria with resistance to isoniazid and rifampicin by Hein for first line, and susceptibility for fluoroquinolona using HINE of second line. Also, DST-2-isonazide, rifampicin, ethambutol, and pyrazinamide, and also levofloxacin was performed in Bactec MIGIC 960 with these concentrations. In the first visit, we collect the history of TB for all the 34 participants. So we are going to talk about these 34 participants who were enrolled. From the results, I want to emphasize that we have two different groups, two conditions. Some of them received first-line drugs for a couple of weeks, and the others didn't. For these people who received the first-line drug in those weeks, some of them didn't have previous TB history. And this is the section, This is the section that I want to emphasize, the resistance of them, that they didn't have previous TB history, and for them, who was 20, they had 90% of resistance to pyrazinamide and 70% of resistance for ethambutol. At the end, or in total in general, for 34 participants, we can say that there is a 77% of resistance to pyrazinamide and 62% to resistance to ethambutol. As far as we know, pyrazinamide and ethambutol are the two drugs that could be used for MDR-TB. So we can conclude that we have especially worrying for resistance of pyrazinamide among patients who had not TB, who had no previously TB treatment or history, and also the exposure to first-line drugs during the waiting period may be selected for resistant pyrazinamide and ethambutol. Also in this region of the eastern of Lima, empiric regimens for MDR-TB determined by molecular tests should not be resumed without having a susceptibility test for pyrazinamide and ethambutol. And finally, the high frequency of resistance to pyrazinamide or ethambutol, even among patients without fluoroquinolona resistance, makes the shortened regimens of limit use in these settings. So this is the staff of research in Lima, Peru. So thank you.
Thank you. Worrying results. Any questions? What? No questions? Yes.
Hi, Bern from MSF. Those are really worrying results, as you say. My question is, do you have any other baseline data in terms of just general susceptibility to pyrazinamide, even in patients who are on the first line treatment? Because obviously then the worrying thing is not just about MDR-TB, it's actually worrying for drug susceptible TB as well.
Well, in the context of this clinical trial, we just used the HINE for first line. So there are the results, but these results are for DST in Bactec MIGIC. So no.
And just a follow up on that is, I understand that this is specific to this trial, but just the context of where you are, whether there's any other prevalence data that shows to high levels of first-line drug resistance.
In the context of Peru country, the result for this kind of participants maybe approximately would be the same. I'm not really sure to tell you the truth, but maybe we can talk together later or at the end of the session.
I think, Bern, there's something a bit fishy, something a bit odd about this, in that you've got more pyrazinamide resistance in those who haven't previously been treated than in those who have. And this is contrary to normal expectations, very contrary to normal expectations. So one possible explanation, it struck me, for that is that you're dealing with an outbreak of a particular pyrazinamide-resistant strain, which is being passed from person to person. Do you have any data on the genetic makeup of the strains that you are seeing here?
Well, the clinical trial at this moment is continuing doing. We didn't end the enrollment process, so maybe at the end, yeah.
No, okay. There's something odd about this. I
okay.
concur with Byrne's concerns. Okay, thank you very much.
Thanks to you.
Right, next is baseline and pharmacokinetic factors associated with individual outcome in the Panacea MAMS TB01 trial. Lessons for the regimen and trial design. Is it Dr. Heinrich?
Yes, thank you. Thanks for giving me the opportunity to speak here. I'll try to be quick, which is unfortunately not my strong side.
Don't worry, you'll do it.
Cut me short. Okay. I'd like to present you results from a small sub-analysis from the MAMS study data that I've performed. And in the interest of time, I'll just focus on one arm of this study, just a brief recapitulation. The study was a 5-arm study which compared 4 experimental regimens to an arm of standard treatment. I will concentrate now on the experimental regimen which was most effective, which was giving an increased dose of rifampicin 35 milligrams per kilogram to the patients. And the full details of the study can be seen in the paper which just appeared in the Lancet Infectious Diseases online today. But not this sub-analysis, of course. This study had a total sample size of 365 patients, and it recruited patients in 7 centers, 3 of which were in Tanzania, and 4 of which were in South Africa. The primary endpoint was time to stable culture conversion in liquid media, I should add. And the main results have been presented already. As you can see here in this Kaplan-Meier graph of culture conversion of all treatment arms, the rifampicin 35 milligram per kilogram arm showed a faster culture conversion as compared to the control regimen, which is here in blue. And in numbers, this translates into a hazard ratio for time to culture conversion, the unadjusted hazard ratio of 1.46, which is, as I said, just reported. And please keep this number in mind. This hazard ratio compared, I myself as a pediatrician, I have always difficulties in understanding hazard ratios. So this compared to a median time to culture conversion of 62 days in control and a reduction to median of 48 days in this 35 milligram arm. Now, pharmacokinetics. I would like to show you just dot plots of time to culture conversion here on the x-axis compared to the area under the curve of rifampicin that was seen in those patients. And so each dot represents 1 patient, and you can see that empty dots are patients who did not achieve culture conversion, and filled dots are patients who received culture conversion at various times. As you can see here in the first slide, which shows all the patients who received rifampicin 10 milligrams per kilogram, including 1 experimental arm and the control, there was not a really good correlation between rifampicin area under the curve and time to culture conversion, and this also translated in the Cox regression analysis to a hazard ratio that was not much different from 1 and was also not significantly different from 1. Now looking at the experimental arms where patients received 20 milligrams per kilogram of RIF, the picture is a bit different. Of course, patients do achieve higher exposures of rifampicin as has been reported, but still there is no good correlation between rifampicin exposure and time to culture conversion. The picture changes when we look at the 35 milligram per kilogram arm, where patients again achieve much higher exposures, which are proportionally increasing with the dose. But even there, it doesn't seem to be the case that all patients really benefit from this higher dose, and we can see that some patients still do not achieve culture conversion at the end of the 12 weeks. But many patients do, and especially this applies to patients who have the higher rifampicin exposures. So this is maybe not a very a good way of analyzing this retrospectively data-driven, but it probably serves for generating the hypothesis. I would just introduce a cutoff of exposure that we would, based on this data, like our patients to be above to have good outcomes. And the median exposure of this dosing group was unfortunately below that. So that means at 35 milligrams per kilogram, not all the patients really did achieve this beneficial exposure.
I'll give you an extra minute, but I think you need to move to conclusion.
Okay. So looking at the RIF exposure and the doses, we can see that the weight-based dosing was not as strictly associated to the actual exposure as was the total dose that patients received, which is a controversy in the field. Given this good correlation of total dose to exposure, I was able to get back to the total trial population and analyze them for hazard ratios according to dose. And you can see here the different rifampicin doses given. And the hazard ratios for time to culture conversion. And you could see that exactly at this high dose here, 2,100 milligram, was where the acceleration of culture conversion was strongest, and the other doses did not see any significant acceleration. Fortunately, this dose did not see excess toxicity. We had some excess liver toxicity in the higher dose rifampicin arm, but these occurred mostly at this dose and not so much at this dose. So to conclude, rifampicin 35 milligram per kilogram resulted in a wide range of exposures. Only higher exposures within this arm seem to be associated to better outcomes, so we just seem to be on the brink of higher rifampicin dose being beneficial. Flat doses correlated to exposure slightly better than weight-based dose, and we didn't see a safety signal at the flat higher dose of 2,100 milligrams. The limitation of this is, of course, that this is data-driven post-hoc analysis for hypothesis generation, and not all prognostic factors really entered this analysis. For example, disease severity, or of course weight, which is the driving factor in our weight-based dosing for patients to receive this higher dose. Thanks very much.
Okay, so now we're deeply down into the arcana of pharmacokinetics. So who dares ask a question? Yes. I think you ought to declare a conflict of interest, should you not? Are you not involved with this study?
No. I'd love to be, but I'm not.
Oh, I made a mistake then. I was mistaking you for the previous one. Could you go to the microphone, Bob, please? Because otherwise we won't record you.
Sorry, yeah, Bob Horsberg from Boston University. Norbert, there's a nice data, and what I'd like to see, I don't know if you have it, is a slide that shows the correlation between AUC and time to culture conversion, because it would probably be a nice curve. Do you have that somewhere?
That's what I tried to show for the different dosing groups. I'm not sure if
but I wanted to leave dosing group out of it, yeah.
These were well,
basically, there doesn't seem to be a relationship between area
at the lower dosing groups, but here there is one at the higher dosing group.
Until you get to a higher dose, yeah.
Okay.
Yeah. Bern?
Maybe
you better give your name and affiliation for the recording.
Okay, Bern Nyangwa, MSF. Just for clarification, maybe I also missed it. So you made a kind of a hypothesis about the total dose being the one that drives the efficacy. The question I'd have is, do you think that would be the same in relation to the toxicity? Whether actually it's not, if it's not the total dose, but it's the milligram per kilo dose that drives toxicity, then that mismatch will be a bit complex to
well, yeah, as you say, it's not. It doesn't seem to be the total dose that drives toxicity. Otherwise, we would have seen more toxicity at this higher dose. But to really iron out with this still relatively small experimental arm of 62 patients, whether it was a milligram per kilogram driver or total dose driver, will probably be a bit difficult. And I must admit, I haven't done that for toxicity. Total dose is a bit better associated to efficacy than weight-based dose. You would see better efficacy in patients who achieve more than 35 milligram per kilogram, because there was, of course, a range in the weight-based dose in that arm. This is data which I haven't shown, but we will have to work on this a bit more intensively before publishing.
Okay, thank you very much.
And one more question, please.
No, thank you. We're running out of time,
Okay.
if you don't mind. You can speak to Dr. Heinrich afterwards. Okay, number 6. Delayed TB treatment response or failure. Predictors and outcomes of month 2 culture non-conversion among HIV-negative patients, a Rifatox trial sub-study. Dr. Atwine, is it?
Yes, Daniel.
Yeah.
Thank you so much. I apologize for a small change in the title, but the information is the same. I'm from MSF, Epicenter, the research arm of MSF, and we're glad to be a part of the Rifatox trial, which was a high-dose rifampicin trial. Below are the co-authors and the affiliations. We looked on the delayed tuberculosis culture conversion among the patients, Ugandan patients who participated in this trial. And I'm glad that the previous presenter gave a good background for this. The 8-week culture conversion has been used in many clinical trials as a marker for treatment response. And the same in the Rifatox trial, which evaluated the increase in dose of rifampicin, 15 and 20 milligrams per kg versus the normal dose. We noted that there were low LJ, which is solid media, culture conversion rate in the Ugandan site compared to Bolivia and Nepal, which were the cause sites in this trial. This phenomenon has been reported in other previous trials, which included African sites, which reported a lower conversion rate at month 2, which questions definitely its validity. So our objective was to further describe what the treatment response was during the different culture, using the different culture media, and to identify predictors of culture non-conversion at week 8 for all patients at the Ugandan site. So it was focused. Very unique to the Ugandan site is that we were able to follow longitudinally with solid media and liquid media, that's LG and Megate, for all patients for the 6 months of follow-up. And I would like to say that the Rifatox trial publication has already been done, as you see. So at this site, we focused on assessing the conversion rates based on the different culture modalities, LG alone, Megate, and then a combined measure. So our patients were really middle-aged, and majority are males, and they were really spread across different occupations, majority non-professional jobs, and they had a high bacillary load at baseline, as you can see, over 80%. So at week 8, 16, and 24, the culture conversion, we tried to compare the different, we compared the different methods, solid and liquid culture conversions. And we noted that there is an overwhelming difference between LJ and Megate at month 4, which can be explained by the reduction in the bacillary load by that time. But with the increase of doses, this difference between the solid media and liquid media become even more profound early, which definitely can be explained by the faster reduction in the bacilli loads, and which reduces the sensitivity of LJ even the more. So we also compared the different conversion rates across arms, treatment arms, but there was no significant difference. So what we wanted to specify here is that the different culture methods that I use really have an impact on the reported conversion rates, and this should be taken into consideration. Sorry. So among the risk factors of delayed conversion, well, after adjusting for age, sex, and treatment arm, the only factor which was close to be significant was occupation, and specifically this group of occupation, the social service. What we mean here, this is a group of people who are involved in transport, motorbike transport. We have that means of transport in Africa, Uganda, borders, and taxi people, which is a very special group, which showed a very higher odds of non-conversion. And so our main findings here are that the low month 2 conversion among Ugandan patients was due to delayed conversion rather than treatment failure. This is that all patients finally converted by month 6, but majority, some of them were still positive by month 4, but converted by month 6 without change of treatment. And then the type of culture media seemed to interfere with the culture conversion rates, more so in the high-dose rifampicin arms, just as we saw. And working in social service jobs, as I mentioned, was really associated to higher risk of week 8 culture non-conversion. So our recommendation is that use of the same culture method, or both liquid and solid media, across sites within the multicentric trials should be really encouraged, and there should be some caution when we are pulling estimates between trials. And lastly, a particular attention should be given to the detection and treatment of people working in social service jobs, because being in social arena, they can easily transmit TB. Thank you.
Any questions? I think you're a danger of reinventing the wheel here. MIGID is known to be more sensitive than LJ, so culture conversion on MIGID is likely to be later. Not a surprise.
Yeah.
What would interest me is, were the social service folks, the guys driving the motorbikes, were they taking their tablets?
Well, they were more associated with having a missed dose, at least.
Yeah. Well, there we are. Not yes. Rocket science. Yes.
I just wanted to know if the social services, although you've already described, they didn't include health workers.
No,
and you didn't analyze health workers.
No, there are no health workers in this population.
Okay, thanks very much.
You're welcome.
Right, next up we have Dr. Kushko, I think. Do we? This is the Ukrainian study. Yeah. So this is the effectiveness of treatment in patients with destructive pulmonary TB depending on the mode of administration of anti-TB drugs.
Good morning, dear colleagues. I'm here to help Professor Kushko to present his materials about different ways of administration of anti-TB drugs. It's a Ukrainian study, was conducted in the National Institute of TB in Ukraine for their government foundation. And the aim of the research was to determine the effectiveness of chemotherapy using intravenous and oral anti-TB drugs in patients with new cases of destructive pulmonary TB. we had 130 TB patients with caverns of destruction, 2 and more. The diameter was 3 centimeters and more of each. And their process was spread on the 2 and more lobes of lungs. So those patients were randomized into 2 groups, and patients from the main group received the standard chemotherapy, isoniazid, ethambutol, rifamycin, and pyrazinamide. These patients received those drugs orally, and the other group was with the same number of patients who received isoniazid, ethambutol, and rifamycin intravenously, plus pyrazinamide per os. The main aim of research was to evaluate the time to sputum conversion, time to disappearing of caverns, and average time to disappearing of symptoms of intoxication due to the destructive process. After only 2 weeks of treatment, we had first results. The symptoms of intoxication disappeared in 97% of patients who received 3 anti-TB drugs intravenously, and only in 75% in the control group who received all those drugs orally. The main duration of symptoms of intoxication in patients of intravenous group was about 9 and 10 days, and in control group it was up to 2 weeks. After completing the intensive phase of therapy, the sputum conversion was founded in all the patients of intravenous group, comparing to 95% of patients of control. The average time of sputum conversion in the main group was about 1 and 6 months. And in the control group, it was longer. In patients with destructive pulmonary TB, time to sputum conversion was a little bit longer in the main group, 1 and 6 months, and over 2 months in the oral group. The average time of cavities healing in the main group was about 3 months, and about 4 months in the control. Well, actually, intravenous method of treatment of difficult, severe TB is widely used in our institution, and during the intensive phase of treatment, it allows to increase the process of healing and allows to shorten the time of in-hospital stay. After we reach the sputum conversion, patients can go home quicker, and they are switched to the oral therapy. The average time of treatment shortens by 2 or 3 weeks, depending on the time of sputum conversion during the intensive phase. So this method, which in our institution is a method of choice in severe situations and severe conditions, allows not only to increase the average time of healing and to decrease their symptoms of intoxication and adverse effects, but it also helps to save their money on treatment. And as in our country, during the intensive phase, patients have to be in the hospital departments. It also helps to reduce the hospital stay. So, thank you.
Very much. Any questions? No. I know you randomized the patients. Did you analyze whether there were differences in the groups? Because these differences are relatively slight.
Patients were randomized by the blind method.
Sure, but did you finish up with equivalent groups, or
they were equivalent, but the one group received 3 drugs orally, and all 4 drugs orally, and the other group received 3 of them intravenously. The main condition was the same.
Yep, one question quickly.
Yes. So were the doses the same?
Could you give your name and affiliation, please?
Oh, my name is Jotam Paspanoja from Baylor in Texas. So I just wanted to find out if the doses for each drug that you used were the same between the 2 randomized groups.
Thank you. The dosage in each group were equal, and they were standard according to the guidelines. Isoniazid in both groups was 300 milligrams per day. Rifampicin and rifamycin were 600 milligrams. Ethambutol was 20 milligrams in each group, and pyrazinamide was also the same according to the standards.
We need to move on if we're going to finish in time, so thank you very much.
Thank you.
Next up is the efficacy of endobronchial valve installation in a complex therapy of destructive pulmonary drug-resistant tuberculosis. Dr. Skluyev.
Good day, dear colleagues. I'm very thankful for the opportunity to make this presentation. As all you know, data regarding the applications of endobronchial valve in treating various pulmonary diseases have recently been published in the medical literature. This drug-free, minimally invasive method is used to reduce lung volume in patients with pulmonary emphysema, to treat pneumothorax in patients with bronchopleural fistulas and/or in postoperative patients, and to treat spontaneous pneumothorax of different etiologies. In Russia, ABV has been used to treat patients with various forms of destructive pulmonary tuberculosis. Despite the widespread applications of this method, very little is now about its efficacy and safety. The objective of the present study is to study the effect of ABV as an interventional among patients with destructive pulmonary multidrug resistant TB. We conducted an open comparative randomized clinical trial to evaluate the safety and efficacy of the ABV to treat MDR-TB. The study was conducted in Novosibirsk Tuberculosis Research Institute. Patients with similar clinical, laboratory, and radiological results were randomized into 2 study groups. All patients had destructive MDR-TB and had received appropriate second-line anti-tuberculosis treatment in accordance with their drug resistance pattern for more than 12 months before being enrolled into the study. All patients were SMA positive and had not demonstrated bacteriological conversion for the previous 6 months. The interventional group included 49 destructive MDR-TB patients who received an ABV in addition to complex second-line treatment. The control group included 53 patients who were administered appropriate conservative complex anti-tuberculosis treatment without ABV. During application on the ABV, special attention was paid to the speed of bacteriological conversion and the effect of ABV on radiographic changes. It's important to highlight the high percentage of patients with bacteriological conversion in the interventional group, 47 within the first 3 months of study enrollment compared to only 20 patients in the control group. Cavity closures were recorded in 33 cases in the interventional group and in 11 cases in the control group. The duration of ABV occlusion in the interventional group was 21 days. Cavity closures within the 3 months of treatment occurred in most patients in the interventional group, 27, and only 2 patients in the control group. Cavity closures in the interventional group occurred within 113 days and 134 days in the control group. The speed of cavity closure did not correlate with cavity size. In the interventional group, the Spearman correlation coefficient was 0.154 and 0.07 in the control group. Long-term 3 years improvement in treatment results occurred in 77 patients, 41 in the interventional group and 36 in the control group. A total of 42 MDR-TB patients from both groups were cured, 33 in the interventional group and 9 in the control group. Relapse was observed in 5 patients, 2 in the interventional group and 3 in the control group. TB progressions was observed in 30 patients, 6 in the interventional group and 24 in the control group. AVB installations lead to faster bacteriological conversion and cavity close in MDR-TB patients. We may therefore assume that it can significantly improve the efficacy of anti-tuberculosis treatment. We believe that further research should focus on the mechanism by which ABV promotes regressions on the TB progress. Randomized controlled clinical trials will provide further characterizations of the advantages and additional clinical aspects of employing ABV as an adjunct treatment for patients with cavernous TB. Thank you.
Well, this looks like resuscitation of collapse therapy to me. Interesting. Any questions? While you're getting to the microphone, you didn't mention any differences in your randomized groups. Were they the same, number one? Number two, were they treated similarly with other drugs? I mean, I'm assuming that you were providing conventional treatment as well, although I didn't catch you saying it.
I'm sorry, I need to translate.
I'm sorry, I'm being unfair. So first question is, were there any differences between the two groups in the drug treatment they were receiving?
Нет, разницы не было.
Yeah, I thought you'd say that. Okay.
Yeah, I was going to ask a similar question and also relate to the severity of disease. I'm Jotam from Baylor. On disease severity before the start of treatment, and it looked like on one of your slides that there were more loss to follow up in the control group, or did you find the similar results when you did an intent to treat analysis? Thank you.
Mm-hmm.
I think, if I may interrupt, in the interests of time, I think a personal conversation might be the best way of getting to the bottom of that one, if you don't mind, because we've got 2 more presentations to go, and we're going to be right down to the line. Thank you very much. It's Professor Krasnov, is it? Yeah. Next up, challenges in supply of investigational medicinal products for MDR-TB clinical trials. Dr. Komska.
Thank you very much. My name is Jan Komska. I'm working for Vital Strategies, and I will be talking about the clinical trial that we are running stream. So we are running clinical trial stream to compare the outcomes of patients with multiple drug-resistant tuberculosis in different treatment groups. We are not going to present any results of the trial. However, I am trying to speak about what we have done before the trial in order to ensure that we have a success of this trial. We are acting as a sponsor of the trial, and we have also taken on us to ensure that all the supplies that are needed for the clinical trial, including investigational medicinal product, are available at all sites for the trial participants. And I will be focusing on supply of investigational medicinal products in this presentation. So these are the challenges that we have. However, these are challenges that I cannot impact because they are coming from the design of the trial. We need to supply a large number of investigational medicinal products. When you compare a clinical trial database in normal clinical trials, you would have 2 or 3 products. In our case, we have to supply 12 products. We need to supply these products for a long period of time, up to 9 months, for each participant. We are running this trial in multiple countries, about 10 countries and about 20 different sites. And some of the sites that we are working with have no previous experience in conducting a clinical trial. And also some of the countries where we are working have not conducted any clinical trial before. So also the regulator, custom clearance officer, everything is new for them. Our objective for us in the supply is that we want to ensure that all the patients that are enrolled in the trial will receive treatment during the treatment course, and that this treatment will be according to their protocol. And at the same time, because the results of this clinical trial will be used by Janssen to support their application to EMEA and US FDA, we need to make sure that the trial is in compliance with GCP guidelines and the regulatory requirements of these 2 stringent authorities. So we have tried to identify challenges that we anticipated. We tried to see what consequence these challenges can have and what is the likelihood that they occur. We then created the scores to rank these challenges, and then we address them through preventive actions and prioritize what action we need to take. So just as an example, I can show you that the catastrophic consequence for us would be that clinical trial is not approved by the authority, and then we cannot enroll the patient, or if we lose stock of medicinal product because of inappropriate storage, theft, or etc. So this was like a helpful table. And then we also scored based on how possible it is that this can happen. And then based on that, we created risk score calculations. And then we were able to focus on at the beginning on this area where the risks were highest, because the consequence would be catastrophic and the challenge would almost certainly happen. Based on that, we have created a list of different challenges. For example, as I mentioned, some regulators were insisting that we need to support documentation that does not exist, because many of the drugs that we are using are generic drugs, And the initial trials were already conducted on them many years ago. So this had to be addressed with them. So based on these different risks, we have then created action points, and we prioritize them in order to address the risk based on their severity. So the most important for us was that we had to establish our buffer stock that belonged to us, because the supply of products was not reliable, unfortunately. It cost significant amount of money to us, but we could justify this based on this risk analysis that we have conducted. We developed forecasting tool for each site in order for them to be able to forecast the amount of products that they will need, because the dosage and the regimens are very complex. We also spend a lot of time in training and education and assistance to the countries, because part of this clinical trial, or the big project, which is funded actually by USAID, is that we build capacity in the countries in order to run clinical trials. We are now in the process of developing systematic approach to evaluate the pharmacies that are in the sites in order for them to be included in the trial, and to identify what needs to be done in order for them to prepare to participate in the trial. And we are also developing electronic stock management system. Thank you.
Thanks very much. Any questions? I hope it doesn't mean that you're getting your excuses in early, and that you're anticipating serious problems.
No, we are not doing any excuses. On the contrary, we are trying to secure enough funding for us so that the results that are very important will be valid.
Sure. Yeah, it'll be the first proper randomized controlled trial for MDR-TB treatment. Okay, next up is the tuberculosis clinical trial activity on the African continent, an analysis of tuberculosis trials registered in the Pan-African Clinical Trials Registry. And this time I think it's Dr. Loutier who's going to be presenting. The floor is yours.
Thanks for coming. Unlike most of the other presentations, I will not talk about one clinical trial, but about many. And so this is a cross-sectional analysis of trials of tuberculosis done in Africa. As you probably know, Africa...
Can you get a little closer to the microphone? I'm sorry if you don't like to do that, but otherwise you will not be heard.
Africa is severely affected by tuberculosis, and although it only has 11% roughly of the world population, it carries approximately 29% of the global burden of TB. 34% of deaths in Africa are somehow related to tuberculosis infection. And of course there is a big problem with co-infection with HIV. About 1 in 4 deaths of HIV-positive people in Africa are also related to tuberculosis. We believe that clinical trials are a very important tool to inform further research, to identify gaps, avoid duplication, and of course very useful for policymakers and health research. This work was done on the Pan-African Clinical Trial Register. I'm one of the working group members, and PACTR is a primary clinical trial register which was launched in 2007. It's run from South Africa, and of course the aim is to encourage registration of clinical trials down on the continent. Initially, it only included trials of tuberculosis, malaria, and HIV. Now it includes all conditions. And most importantly, in the last few years, PACTR has been included on the WHO clinical trial platform, and is the only African clinical trial register to be included. So for the methods, we searched PACTR, and we did essentially a cross-descriptive analysis. We extracted data from the trials that we found. The search was done between 2009 and March 2016. In that period, there were 661 trials in total for all conditions registered on PACTR, and 53 of these were tuberculosis trials. When we analyzed the type of interventions, the vast majority were intervention of treatment, drug treatment, 5 were prevention trials, and of these 2 were with vaccines. A good number of the trials were about diagnosis, new rapid diagnostic tests. 5 were education and counseling, and 4 were about supportive care. Regarding the sample size, it was varied. There were some very small ones and some very big ones. Just for curiosity, of course, this depended on the type of intervention. So the really small one was actually a trial of lidocaine to reduce the pain of injection of tuberculosis drugs. And the really big one, 27,000, was a trial that analyzed the role of informal healthcare providers in diagnosis and screening for tuberculosis and other pulmonary conditions. However, as I said, the median was a few hundred participants. The age range covered all ages. 14 trials included only children. 10 were of children and adults, and the rest were run in adults. Funding source is not always easy to identify, despite obviously being one of the fields that trial registrants have to fill up. But from our analysis, almost all funding came from out with Africa. There was no industry funding, and most of the funders were research foundation and non-governmental organization. 18 were funded by the European Clinical Trial Development Program. PACTR has a very useful function, which is a map of Africa where you can search for the trials and you can export, so it's very visually very useful. And so when we analyzed the location of the tuberculosis trials, as you see, they were clearly clustered around the eastern coast of Africa. And the colors refer to the number of sites. So as you see, many sites were found in South Africa, Ethiopia, and Uganda. There were a few clinical trials run in West Africa and just a couple in Egypt. Of course, we would like to understand the reasons for this, if it is the distribution of the disease or whether it is actually research capacity. Another way of analyzing research capacity is to identify where the principal investigators come from. Out of 53 trials, 41 principal investigators were based in Africa, which is obviously a very good sign. And again, most of them were residents in African countries on the eastern seaboard. And there were also several, there were 12 principal trial investigators, which were obviously from outside Africa. This analysis is still ongoing. It will be presented, and of course there will be much more to it. The provisional conclusions are there is a good number of clinical trials of tuberculosis run in Africa. I also want to say that PACTR has been expanding very much. So each year we have a good increase in the number of clinical trials for all conditions which are registered, which is obviously very, very useful. The focus of the TB trials was on treatment, which is to be expected. As I say, most trials were clustered around the eastern seaboard. And we do believe that the information from these clinical trials can be used, especially with identifying gaps in research, and also may help plan future research for policymakers, funders, etc. I just want to thank, of course, all the people who registered the trials, the WHO ICTRP that has accepted the PACTR as one of the primary register on it. As I say, the PACTR is run from Cochrane, South Africa, and the South African Medical Research Council. And also, I'm associated with the Cochrane Infectious Diseases Group here in Liverpool, and as I say, as a member of the working group. Thank you.
Thank you very much. Any questions in the last few minutes to Dr. Luthier? I noticed you had some Gambian investigators, but I didn't see any trials in the Gambia. And I wonder whether you're in touch with the Medical Research Council in Fajara in the Gambia, who I'm sure are conducting many trials.
Okay, one thing I should clarify is that, Obviously, registering trials on PAC3 is voluntary. I mean, we do a lot of dissemination, a lot of encouraging people. So, we go to meeting, we talk to people, because we really think that it's important that African trials are registered here. And doing so, they automatically get also registered on the WHO clinical trial platform. But of course, a lot of people register their trials directly, let's say, on clinicaltrials.gov. So these, especially at the beginning, our register was really encouraging African scientists. We did a lot of, as I say, explanation. We helped people to register trials. I mean, 10 years ago, doing it electronically was not always possible, so it was done, by paper. So there is a much more local level of communication, and we also work very closely with the individual countries' trial registry.
Good.
But as I said, probably major organization might go directly to clinicaltrials.gov.
Okay, thank you very much.